Mr. President, Mr. Chairman, ladies and gentlemen, thank you for the opportunity to present my experience in the US today. We flew first of all to Atlanta, to Dr. Doug Murphy's institute, and following that we flew on to Philadelphia to France at Lankenau Medical Center. Our aim really was is part of our staged introduction of robotic cardiac surgery into Liverpool heart and chest. When I spent my year with Dr. Chitwood said to me that the introduction of robotic surgery is like climbing Everest. You can't go straight from a stenotomy to a robotic operation. It's just too big a jump. You need to go through the minimally invasive mitral or mid-cab stage, depending on whether you use mitral or coronary surgery. Because the bailout, if you have a problem with the robot, is just to undock the system and just convert the operation to using long-shafted instruments through the same incision. And we've already moved from base camp 1 up to base camp 2 with our introduction of minimally invasive mitral surgery. And I think robotic surgery, more than anything else, is a team effort. So I thought it extremely important to take our whole theatre team with us, and the Ionescu Fellowship allowed me to do that. From left to right, we have Alistair Marshall, who's one of our surgical care practitioners and president of the SCP Society. Flora Bell is one of our scrub nurses. Nika Cope is one of our managers. And I thought having management buy-in with robotic surgery is absolutely vital. Ian Johnson is one of our perfusionists, and in the background we've got Ken Palmer, who is our anaesthetist. And as I said, robotic surgery, I think more than anything else, requires a team approach because the surgeon is in the corner of the operating theatre with the team around the patient. So we first went to St. Joseph's Hospital in Atlanta to Doug Murphy to learn what's been called the LEAR technique, so the lateral endoscopic approach for robotics. For robotic mitral valve repair. And I'd already spent a year with Dr. Chitwood and learned a slightly different version of the operation. But in my year with Dr. Chitwood, I'd heard about Dr. Murphy. So it was on my hit list, so to speak, of someone to go and watch. And it really was a fantastic experience there. We spent 3 days there. If you can believe that complex mitral and tricuspid valve surgery is done with this setup. The first day we were there on the Monday, we saw a robotic mitral and tricuspid valve repair for type 1 dysfunction due to annular dilatation from AF on a lady in her late 70s. She was extubated on the operating table. Day 2, we saw a 45-year-old Delta pilot who had a P2 prolapse. Again, extubated on the operating table. 1 night on the intensive care unit for monitoring. We saw him the following morning. He looked absolutely fantastic. And day 3, he operated on a 50-year-old orthopaedic surgeon, also with posterior leaflet prolapse. Absolutely phenomenal results. And back to work. The plan is, we were told, back to work in 2 to 3 weeks. From there, we flew up to Philadelphia and to Lankenau Medical Center. On the west side of Philadelphia, to learn robot-assisted midcabs. This is essentially harvesting the left internal mammary with the robot, and then doing extending one of the ports, the end of the 3D endoscope port, to do a hand-sewn anastomosis. And really, the incision is just slightly wider than the width of your index finger. That's all you need to get in your finger to tie the knots. I chose Doug Murphy and Fran Sutter really are at the top of their profession, and it was a phenomenal experience. If you can believe that a coronary operation can be done through that incision, well, we saw 2 cases whilst we were there on the Thursday and Friday. Both patients were thrombocytopenic with one had a platelet count of 40,000, the other of 50,000. Both had the lemur grafted onto the LAD, and if my video works, yep, that is the total blood loss at the end of the operation. absolutely phenomenal. And this is what's happened to the volume in Lankenau Medical Centre, where the green line represents their annual volume prior to the introduction of robot-assisted mid-cab, and the red line shows the massive increase in referrals from both from around the US and internationally following the setting up of their robot-assisted mid-cab programme. What were our key learning points? Well, both programmes were extremely successful and, as I said, attracted referrals from around the US, and both of them had an international reputation. They both kept the robot team constant. It's complex technology, and having the same team day in, day out was emphasised by both Doug Murphy and Fran Sutter as being very important to a successful programme. How have things changed our practice with our minimally invasive mitral valve surgery in Liverpool? Well, Doug Murphy routinely used retrograde cardioplegia, and we've adopted that also. As a consequence of that, we now don't need to cool the patient as far. So we used to cool to 28 degrees and plege every 30 minutes. Now we just cool to 32 degrees and our maintenance cardioplegia is given retrograde every 20 minutes. The advantage of that is that patients can be extubated a lot quicker because they don't cool down on the intensive care unit afterwards. The second thing we've already changed, both for the mid-cabs and the mini-mitrals, is the routine use of lots and lots of local anaesthesia. So using 60 mils of 0.25% kyrocaine, putting 20 mils in the paravertebral space, 20 mils as intercostal blocks, and the remainder in the incisions, and that gives generally very, very good post-operative analgesia. We observe major patient benefits, all related to the reduction of surgical trauma, and I think this is clearly going to be a massive growth area for cardiac surgery in the future, less invasive surgery. Interestingly, probably the greatest benefits, and both Doug Murphy and Fran Sutter emphasised this, is in the highest risk patients.